All right, good afternoon, everyone. 10 minutes, lots to discuss, so let's get started. We know lung cancer is molecularly very diverse. It is a heterogeneous disease. And if we go into the subset, and I just look at the adenocarcinoma subtype, BRAF mutations constitute for around 2%. And in addition to this, we also see BRAF as concomitant mutations with other oncogenic drivers or other passenger mutations. And this is why, with the advent of NGS, it's becoming more and more important to kind of look at all the mutations that are present at the get-go in your patient's tumor. Now, BRAF testing is recommended upfront but in the NCCN guidelines, irrespective if it's adenocarcinoma, NSC, squamous cell, or large cells. So upfront, it is recommended. Let's focus a little bit on BRAF. What do we know about it? It constitutes for around 2% of our lung adenocarcinomas, predominantly non-smokers, women, the aggressive histological subtype. The BRAF V600E is the most common. However, the buck doesn't stop with BRAF V600E. In fact, BRAF mutations are classified into 3 types. You've got class 1, class 2, class 3. Class 1 mutations are essentially where you see a BRAF V600E, K, D, R, which occurs in the valine residue at amino acid position 600 of exon 15. And what this does is it promotes activation of the MAP kinase pathway, which in turn leads to the strong activation of BRAF kinase. So it actually has sensitivity to a BRAF and a MEK inhibitor, both of them combined. And this is what we generally tend to see. Then we have class 2, where you've got your other mutations, and we see a lot of these too in our lung cancers, the K601, we see the G464, G469. Now, these mutations are structurally very different from your class 1 mutations, and based on its position in the P loop and the signaling that it has in the RAS pathway, these tumors which have these mutations that classify as class 2 are known to be highly sensitive to a standalone MEK inhibitor. Then we've got our class 3 mutations, again structurally very different from class 1 and class 2. Over here, the P loop, the catalytic loop, all of these activate the MAP kinase signaling pathway and in turn the RAF1 pathway. So here we really don't know if your tumor is going to be BRAF inhibitor sensitive or MEK inhibitor sensitive. But there are a lot of drugs that are along the way in the pipeline that are there. But when you see a BRAF mutation, which is not your classical V600E, it becomes extremely important to understand which class are these BRAF mutations so you can accordingly decide therapy. And it's not just this. In fact, we do have other BRAF mutations. You've got your BRAF deletion mutations that are known resistance mechanisms to your BRAF inhibitors with your MEK inhibitors. And these have a very similar structure to your class 1 mutations. Then you've got your BRAF fusions. Yes, you do see BRAF fusions. And here where it's important to see which is the BRAF fusion partner. There are around 18 fusion partners that are there that are recognized. The AGK fusion partner in the prime, 5' end, is one of the most common mutations, common fusions that we see. And again, these can sometimes be resistance mechanisms. How do we treat it? We're not really sure. The data is very conflicting. While they're very similar to your class 2 mutations, but how do we therapeutically treat them? I think that's a little bit of a gray zone. There are some functional studies that show that the patient can respond to a MEK inhibitor, and there's some that show that there's no response. So this is work in progress. So the treatment landscape, we've understood the different type of BRAF mutations. We know their different classes. We know the resistance mechanisms. So while we know BRAF V600E is the most common, these have a poor prognosis, and when administered even with chemotherapy, surprisingly, they're very insensitive to your platinum-based chemotherapy. The class 1 mutations tend to be less aggressive versus class 2, class 3. We do see in the class 2, class 3 brain metastases being one of the phenotypes that we see in this particular cohort. Now, with BRAF mutations, they do have a limited response to immune checkpoint inhibitors. I again feel the data is divided. In lung cancer, we do say that there's a limited response, but I know a BRAF V600E in a triple negative breast cancer actually confers immune sensitivity. So it is a gray area. We are again getting a lot of information. In some cases, yes, it does say a patient does have a decent response. And in some cases, because it's an oncogenic driver, it says that the response is abysmal. Targeted therapies are your MEK inhibitors, again, not for all, and in some cases, depending on the class, a combination of MEK and BRAF inhibitors. Now, while we are treating these patients with these BRAF and MEK inhibitors, do remember there are resistance mechanisms that are already in place. So, one of the most common, resistance mechanisms that we see is the NRAS Q61K, the KRAS G12V. These are commonly seen after a patient's been treated with a BRAF and a MEK inhibitor. And this is where NGS becomes extremely important, because a lot of these BRAF mutations have concomitant mutations from the get-go. They could be harboring a PTEN, a TP53, they could be having a mutation in the PI3K pathway. And all of these, while may not be therapeutic, but they are indications of resistance mechanisms that are lurking around, and also indications of a poor response. So this is just the timeline of the treatment options that are available. We do have new drugs. We've got encorafenib and binimetinib, which is again a BRAF and a MEK inhibitor. Unfortunately, still not available in India. Sample type. Okay, so your sample type over here can be tissue, but if tissue is an issue, liquid. And liquid, again, ctDNA. Now, when you're taking ctDNA, ensure that there's a 14-day washout period between the chemotherapy cycles. Another very important thing to note is that when we do this testing, if your tissue does not give you an actionable biomarker as a reflex, please do a liquid biopsy. And if your liquid biopsy does not give you an actionable biomarker, do a tissue biopsy. This is as per the IASCLC consensus, where they've actually seen that complementary testing does increase the uptake of finding a potential actionable biomarker. And do remember, lung cancer is heterogeneous by nature. So how do we test them? Now, we all tend to say that we just have to do BRAF V600EK, but I showed you a host of different mutations. These mutations are in exon 11, which is another hotspot area in BRAF, which is not covered in RT-PCR. So if you are looking in particular for V600E, it's fine, go ahead and do an RT-PCR, but what we are learning now, and we have learned with our other oncogenic drivers, getting the full picture is extremely important. IHC. Nothing wrong in doing an IHC. I mean, it does have a good sensitivity, but in a lung setting, it's not just about knowing if your patient is BRAF positive. You need to know what type of mutation. Is it a fusion? Is it a deletion? All these make a difference with the type of treatment you're going to choose. And that's why NGS kind of trumps. And I'm not belittling, these are standard of cares. These are gold standards in their own right. But considering we have limited tissue, we need a host of information. We know there's so much crosstalk between different drivers that it becomes extremely important getting the entire picture. And this is why NGS is important. I have 2 minutes left, and I'm very quickly going to walk you through case studies just to help understand how we've seen this in our clinic. So this was a 65-year-old female non-smoker, upfront diagnosed with NSCLC in 2016. She had brain mets, so we did not an NGS, those days we did RT-PCR, the typical standard. We had an EGFR exon 19 deletion was detected. She was started on whole brain RT with geftinib, did relatively well, had progression in 2019. Progression was in the bones. We couldn't access for a new metastatic, for the new metastatic site. So we did ctDNA, and here we used ddPCR. We found an EGFR T790M mutation. She was started on osimertinib. She eventually did have progression. Again, we did ctDNA testing, and we found, my test seems to have, here you go. We found a BRAF mutation. We found a BRAF mutation, so she had lost the original driver EGFR and had acquired a BRAF mutation. Now, in this particular case, I don't have the VAFs here, but what had happened was the VAF of EGFR was 0.1, and the VAF of BRAF V600E was 6.2%. So we started this patient on a BRAF MEK inhibitor combination. Also, interestingly enough, BRAF V600E is a known resistance mechanism to osimertinib. Second case, 37-year-old male, adenocarcinoma, upfront, tissue, liquid, both were done, no mutation was detected. We sent it in for PD-L1 testing, 95%, no-brainer, negative for oncogenic driver, was started on pembro and pemetrexed and carboplatin, six cycles, partial response, continued with another 4 cycles of the same combination, did a PET scan, and there was massive progression. So at this point, we took give me 1 minute, please. We took a rebiopsy from the new metastatic site. We sent it in for complementary testing. Young individual, desperate, non-smoker, sent it in for a liquid and tissue. And we did wait for a 14-day washout period, even post doing the PET scan. And this is what we found. We found a KEAP1 mutation on the tissue. And this is why it's important doing liquid and tissue. If tissue doesn't give you an actionable biomarker, interestingly enough, our liquid did. It caught a BRAF mutation. And look at that VAF. It's as low as 0.09%. And there was a host of other mutations. So we took this to a molecular tumor board. We kind of dissected the report. We had a BRAF V600E. No-brainer. Give a BRAF and MEK inhibitor. And what was interesting is the reason the patient was not responding to immunotherapy, and we were not getting the response we wanted on a chemo IO, was because there was a KEAP1 and an STK11. KEAP1 confers chemo resistance and STK11 immunoresistance. And last case, 79-year-old female, non-smoker, upfront, EGFR del 19, started on afatinib, progressed. This was at the peak of COVID. We didn't even attempt doing a rebiopsy. EGFR T790M started on osimertinib. Progress, again, sent it for a sample. Rebiopsy was not an option. And what we saw over here was that in addition to the EGFR mutation, this was her original del 19 mutation. She had acquired a V600E. Now, imagine doing a combination of OSI plus Debra plus trametinib. That's toxic and taking her age in. So what we did here, it did look like EGFR was still the dominant clone, so we continued osimertinib, and we added a MEK inhibitor because MEK is downstream to BRAF. So we removed the debrafinib, we kept the MEK inhibitor, and I'm happy to report that she's doing relatively well. And on that note, thank you very much for your patient listening.